how to solve the puzzle of complex congenital heart disease and discuss mostly about dextrocardia. To start with, some of the complex lesions that we see as adult cardiologists are tetralogy of Fallot. If somebody asks you what is the commonest cyanotic congenital lesion that we see, that's TET. Then Eisenmenger syndrome is reversal of shunt with pulmonary hypertension, and the shunt can be at any level. Ventricular septal defect is the commonest. PDA, ASD is the least common. But single ventricle, if the pulmonary artery does not show pulmonic stenosis. So all these lesions can lead to severe pulmonary hypertension, reversal of shunting. So they'll come under Eisenmenger syndrome. Epstein's anomaly also can be cyanotic because there is severe tricuspid regurgitation and patent foramen ovale, part of this anomaly. Complete transposition, we don't see cases who have not undergone surgery most of the time in adult practice. If you see it, then it'll be VSD and pulmonic stenosis combination, which is complex and it's protecting the lung, but some sort of shunt may have been done for that patient. Otherwise, we see post-operative transposition patients, which is mostly mustard, and we have started to see some switch in adults. Pulmonary atresia VSD is very similar to tetralogy of Fallot, so they also have undergone surgery most of the time. Some maybe just with shunt, and you'll encounter those cases. Occasionally truncus, they also have undergone surgery. Tricuspid atresia, Fontaine, single ventricle Fontaine. Rarely total anomalous pulmonary venous connection, who also have undergone surgery. But I've seen 2 or 3 cases which were totally undiagnosed. And mostly we see post-operative complex congenital heart disease. It may be just some kind of shunt, like BT, Glenn, bidirectional Glenn. Waterston, very rare. POTS, 6 extremely unusual. Then mostly we see tetralogy of Fallot, who have undergone surgery, mustard, switch for complete transposition, Fontaine for single ventricle physiology, and Norwood also have started to come into our practice now. So you take a very puzzle-like approach, segment the heart into 3 segments, atrial segment, then the ventricular segment, and the arterial segment, and determine the overall position of the heart. Then put all these segments together, you know basically what's going on inside the heart with that approach. The first is atrial segment, and if right atrium is on the right side, left atrium on the left side, then that's normal in nature. So the term for normal is Solitus. So that's Situs Solitus. That means it's normal, right on the right and the left on the left. Left atrium tends to be a little bit posterior and left as compared to the right atrium. This also corresponds to the visceral arrangement in the abdomen. Liver will be on the right, spleen will be on the left, stomach bubble on the left. So that's why the term is visceroatrial situs. They go together 95% time. If you see liver on the right and spleen on the left, IVC on the right, descending aorta on the left, that's normal arrangement of viscera in the abdomen, and that will correspond to normal position of the atrium. In the atrial segment, we also include what is inside the atria. So you have 3 systemic veins in the right atrium, SVC, IVC, and coronary sinus, and you have 4 pulmonary veins in the left atrium. So there can be anomalies of those veins, and also there is atrial septum between the 2 atria, so there could be defects in the atrium. So atrial segment, you want to make sure right is on the right, left on the left, no ASD of any kind, which we have gone through previously, and no anomalies of the pulmonary or systemic veins. If there is inversion of this arrangement, that's called situs inversus. That means right atrium has gone to the left side and left has come to the right side. If it's neither solitus or inversus, is confused situation, that's called situs ambiguous. If you look in the abdomen in situs ambiguous, you may have absent spleen. Absent spleen means it's a right side in the body, right? Right side does not have a spleen. So it's also called bilateral right-sidedness. Or you can have multiple spleens. Spleen is a marker of left side. So that also may be called bilateral left-sidedness. So if you look in the heart in those two situations, bilateral right-sidedness, there are certain defects which are commonly associated, which I'll show in a moment. So you can divide into bilateral left and right in the situs ambiguous, because that reminds you of certain defects you should be looking for. Like pulmonary veins, it's a left-sided thing, right? If you have total anomalous, that means it must be bilateral right-sided. It's very common in asplenia syndrome. Having
explain the bilateral right-sidedness and left-sidedness again, please?
I will come to it.
Okay.
Yeah. So then second segment is the ventricular loop. Normally right ventricle, morphologic right, is on the right side, left is on the left side, right? This is due to rotation of the tube as the heart is developing in the fetus, which I will illustrate in a few minutes. Normally the tube rotates to the right side, and right, the term is dextro. That means it's a de-looping, and that de-looping places the right ventricle on the right and the left on the left. If in the fetus it rotates to the left, it's called L-looping. That will reverse the ventricles. So LV will come on the right side. That happens in corrected transposition or L transposition. We'll talk about it in a minute. So de-looping is normal situation, L-looping is abnormal. Portion of the ventricle, inside the ventricle, then you look what is happening to the atrioventricular valve. Like tricuspid is a right-sided valve. Is there abstinence or absent tricuspid atresia? So you look at those. So that's part of the ventricular segment. And septum, are there any kind of VSDs, etc. So this is all assessment of the ventricular segment. The third segment is the arteries. Normally there are two of them, aorta and the pulmonary artery. Normally aorta is posterior to the right, inferior and inferior as compared to the pulmonic valve. I know it's all very confusing right now, but I'll show you nice pictures that will make you understand. And the aorta connects to the left-sided left ventricle. Pulmonary artery is anterior, superior, and on the left. So you wonder how it connects to the right ventricle. It's on the left side. There is a longer outflow tract on the right ventricle. So that allows it to connect to the right ventricle. So PA is anterior and connects to the right-sided right ventricle. AO is to the right, posterior, connects to the left-sided left ventricle. So those are the normal positions of these two valves in the arteries and their connections. Okay, so if you see all of those completely normal, you say Solitus relationship of the arteries and connections. If it's inverted, then it's inverted. So we'll go through some examples and see. Also, you look at the semilunar valves in this segment. Is it bicuspid on the aortic? If it's only one artery, then you call it truncus. If one artery is atriatic, pulmonary atresia. So things like that. So you have two arteries normally connected, not normal connection, single artery truncus situation, or other problems. And within the arteries like patent ductus, collaterals, and coronary artery anomalies, you evaluate that. So these are the three pieces of the heart, then put the puzzle together and you have the complete diagnosis. Then finally look at the position of the heart. Normally the heart is mostly positioned in the left chest. So you call it Levocardia. Levo is left. So it's a left-sided position or situated heart is in the left. If it's on the right side, use the term dextrocardia. And meso is in between position. So this is the development of the heart in the fetus. It's a straight tube to start with, and this portion produces the atria, this produces the ventricle, this bulbous cordus produces the outflow tracts. On the left side it gets absorbed, so you have a smaller LVOT. In the right side it stays patent, leads to a longer RVOT. And the truncus is single artery. There's a spiral septum that develops in it, which divides it into aorta and pulmonary arteries. So at 6 weeks or so, I don't remember exactly, but somewhere there, this tube rotates to the right side. And this shows the right rotation of the tube. From this portion, the left ventricle develops. As it rotates to the right, right develops from this portion, bulbous cordus. Okay, so this will place the right ventricle on the right side of the subject, and the LV on the left side. If it rotates on the left side, then this portion leads to the development of the LV. So LV will come on the right, and morphologic RV will go to the left. So that's called the L looping of the tube. So looping is important for positioning the ventricles in the normal or abnormal position. So this sketch shows you the three pieces that I just discussed. You break down the heart into three pieces, three segments, and then join them together like a puzzle. So the first piece is the atrial piece, second is the ventricular piece, and third is the arterial piece. And this is situated in the left side, so it's a normal levocardia, it's a normal segmentation here. The atrium, you have the right and the left atrial septum, the appendages, the three systemic veins, and four pulmonary veins on the left. So you analyze all of them and see if there is any anomaly. Then in the ventricle, the atrioventricular valves, like right AV valve is tricuspid, left mitral, you have two leaflets, here you have three leaflets. They belong to the ventricles. If I put the RV on the left side, tricuspid will go with it. Likewise, if I put LV on the right side, the mitral will come with it. So they go together. But if there is any anomaly of those two AV valves, you analyze in the ventricular segment. The third is the arteries. It's mistakenly shown here, the semilunar valves, but they stay with the arteries. So you look at their connections and any abnormality of those, any abnormal connections within the arteries, like PDA. So this is that concept of Situs ambiguous. On the left, you see the normal. In the normal, you have the trachea. It bifurcates into right main stem and the left main stem. Anybody knows the difference between right and left main stem bronchus?
The right is more in line with the trachea.
Is thicker, shorter, more in line. And left is longer, thinner. Foreign bodies go on the right more so because of that kind of angulation. The right lung and left lung differences: three lobes, trilobed versus bilobed, right? So these are the morphologic anatomic features of the tracheobronchial tree and the lungs. So that's the Solitus position. Liver on the right is Solitus, stomach bubble, and the spleen. So this is everything is arranged just like it should be. So that's normal or typical or Solitus. All three terms mean the same thing. Then here we've shown the right atrium on the right side in the body and the left on the left. These appendages, LAA, left atrial appendage, is a smaller base. Opening is smaller. It's a corkscrew-like, finger-like projection. On the other hand, right atrial appendage has a broader base, and it, like a apex, like a pyramid. So those are the morphologic features of the atrial appendages. So all these anatomic landmarks and features allow you to say which is which. Is it right or left? You go as unknown, and you have to figure it out. So you need the imaging tools. It could be simple EKG, it could be echo, it could be CT, it could be MR, all of the above. But echo is the simplest and very accurate and on bedside and quick. You can't see the lungs, of course. For the lungs, you need the chest X-ray or the CT. So this is the normal arrangement or situs solitus. Here no ventricles are shown because this situs solitus terms only applies to up to the atrium, right? If you see everything normal, you assume atrial position is normal. Then look inside the atrium, make sure, yeah, it is, because there's always exception in medicine. So in this one, everything is inverted. So that's situs inversus. Here the spleen has come to the right side, and liver has gone to the left side in the abdomen. And we have switched the lungs. Trilobed lung has gone to the left. That means it's morphologic right lung. So it's inverted. The bronchial morphology is changed. So this kind of bronchus is called arterial, EP. Oh, here. That is the term used for the right morphology. And hip arterial is the left, longer, thinner, and more angle. So this is inverted, so this is situs inversus. Now in this sketch, you see the liver is in the middle, stomach is in the middle, so you can't say is it right or left. It's definitely not solitus or not inversus, right? It's in between. But if you look at the lungs, both lungs have three lobes. So what does that indicate? These are both right-sided lungs. Morphology is just like right lungs. How about the both bronchus or bronchi? They look like right or eparterial type. That means this situation is this is copying everything just like right. So it's a bilateral right-sidedness. If you look in the atrium, both atrial appendages have morphology like right. I mean, it's not possible. It looks somewhat like right. So in this one, the pulmonary veins are divided. All veins are features of left atrium, but here they are not connecting. They may be anomalously connected. So total anomalous is very common in this condition. So you start with this is neither Solitus nor Inversus, so this is Situs ambiguous. But you further analyze that ambiguous, it looks like bilateral right type. And if you analyze this one, it's bilateral left type or bilateral left-sidedness. The feature of left side is spleen, presence of spleen, right? So you have multiple spleen. This is also called polysplenia syndrome. Okay? Asplenia, spleen absent, what infection will be common? Pneumococcus. So you prophylax them, right, for that. And polysplenia, what do you see in the blood? Or asplenia? Howell jolly bodies, and some of the features go with those. So here both atria are more like left type. Actually, they made a mistake here, so I straightened it out. So both are left type in this. Is that clear now, Pawan? Okay. So now you look at the heart from outside. This is the right atrial appendage morphology. I said broad base, and it looks like a pyramid. So triangular pyramid-like with a broad opening is right atrial appendage morphology. You see this, yeah, you say, yeah, this is right. If you see the same thing on the left side, yeah, it's bilateral right-sidedness. Similarly, this is the left atrial appendage. Normal morphology is hook-like or finger-like with a narrow opening. And if you see on both sides, bilateral left-sidedness. If you open them, you can see it. You know, this is a broad base and pyramid-like versus this may have multiple lobes and narrower opening. If you look inside the atria also, this thick ridge is common on the right side. That's the morphologic feature of the right atrium. On the other hand, this thin septum primum is on the left side. So you look at all these features and say, yeah, this is right atrium, this is left or bilateral right or left type. So we start with the subcostal approach. In the subcostal, you get a transverse cut, and this is the vertebral body, patient's right, patient's left. So in the abdomen, IVC is anterior and to the right, under the liver. Abdominal aorta is on the left side, right? Everybody knows that anatomy. So this is very constant. If you see that, that tells you atrial position is normal. Right is on the right, left is on the left. If it's switched, on the other hand, you see aorta on the right and IVC on the left, then you know it's inverted. CT will show the same thing. Then you can also peep in the liver should be here in a normal situation on the right, spleen here. In this one, spleen will be on the right and liver will be on the left. So you're dealing with situs inversus. Atrial position is also switched. On the other hand, if you see this, IVC is anterior a little bit to the aorta on the same side, on the left. That's typical of asplenia or bilateral right-sidedness. So bilateral right-sidedness helps me in thinking that pulmonary veins don't belong to the right atrium. So if it's right atrium type, they shouldn't connect at all. So that means total anomalous pulmonary venous connection should be very common, and it is in this condition 80%. Otherwise, many people don't actually getting away from this concept of bilateral right or left, just cite as ambiguous and then further analyze. But it helps me remember that total anomalous is very common if you have bilateral right-sidedness type of situation or asplenia type of situation. On the other hand, in polysplenia, IVC interruption is very common. So 80% here, 80% here, because IVC doesn't belong to the left side. Does it make sense, Pawan? IVC is a right-sided structure. If you have bilateral left type, there should be no IVC, it should be interrupted. Right-sidedness should not have any pulmonary veins, they should be interrupted. So a couple of lesions so common, it helps you think and remember them and you look for those. Okay, so we looked at the first segment and Solitus, Inversus, right and left-sidedness. The next segment is the ventricles. So you go look inside, you don't know, right maybe on the right or on the left. So going in, when you look at these patients, you don't know what is going on. But you know, right ventricle has a tri-leaflet atrioventricular valve called tricuspid valve. So you look for which ventricle has 3 leaflets in the AV valve. Which ventricle has moderator band? Moderator band indicates right or left? Right. And 2 papillary muscles, mitral valve indicates left ventricle. Also left ventricle is much smoother. Right is very trabeculated, rough looking. So you just look at those 3-4 features, and tricuspid valve is a little bit inferior as compared to the mitral valve. So everybody will have one or more of these features, more the better. So then you know this ventricle is right type or left type. If it's positioned on the right, that's good, it's normal. If it's on the left, it's the L transposition or corrected transposition. And the third segment, nicely shown in this slide, is the relationship of the 2 great arteries. See, now aorta is a little bit posterior, a little bit inferior aortic valve as compared to the pulmonic valve. Pulmonic is anterior, longer outflow tract, and it connects to the right-sided morphologic RV, which is more trabeculated, has a moderator band, has a tri-leaflet AV valve. So that statement makes all the features of the RV. Aorta and aortic valve little posterior, slightly inferior on the right as compared to the pulmonic valve, and it connects to the left-sided morphologic LV. So these are all the connections of it. Then the various situations in the great arteries. Normally you like to have these 2 and how they were wrapping around, that kind of normal relationship. But you may just have a 1. Truncus never divided into 2. So that situation is called common truncus or truncus arteriosus. Or there may not be any pulmonary arteries. In truncus, the pulmonary arteries come from this main trunk. So this is the aorta then, and this is the common trunk, and there are the pulmonary arteries. In this situation, there is no pulmonary artery. So it's pulmonary atresia. The lungs are being fed by these channels coming out of the descending aorta. They are called the aortopulmonary collaterals, APCs. Before they were using the term bronchials, but its more standard term is APC. Or aorta may be hypoplastic in left heart syndrome. So one or the other artery may be hypoplastic or atratic. And so these are different variations of the arteries. And this is completely normal. Then you read different terms like concordance or discordance, and they apply to atrioventricular connections and ventriculo-arterial connections. Now right-sided morphologic RA should connect through right-sided morphologic tricuspid valve to right-sided morphologic RV. Right? I said everything. So this is normal. So it's called normal atrioventricular concordance. Okay. Similarly, on the left side, LA through mitral valve to the LV, atrioventricular discordance or concordance. Concordance. If in this example, RA through mitral valve is connecting to the LV, what would you say? Atrioventricular discordance. Similarly, on the left side, discordance. Here is ambiguous. You can't tell because you don't have those features to tell which ventricle is which. Now this is a normal 4-chamber view. Right atrium, left atrium. We labeled it, but you saw the IVC on the right, so you know it's going to be right, right? And you look at some other features that I described, that's how you know this is right atrium on the right side. Then you look at the second segment. So you look at this valve. Don't say it's tricuspid because you don't know that yet until you see the features. So there is a AV valve here, this is the AV valve here. This is the apex, inferior. This is head, superior. Which one is more connected inferiorly? This one or this one?
First one.
No, this one, right? So this connects here, and this is much higher. This much higher is a feature of mitral valve, bileaflet mitral valve. And this lower is a feature of tricuspid valve. So looking at this, we know this is tricuspid, this is mitral. If this is tricuspid, it should be contained in the right ventricle. But don't believe one thing, although it looks very clear. Sometimes they look at equi-level, you don't have the difference. Look at the other features. This is the typical appearance of moderator band. And this ventricle has a lot of trabeculation, these things projecting. In real time, you see it better. So it has more trabeculation, it has moderate band. This has a valve that is more inferiorly connected. So all these are features of RV. So we know very confidently that this is RV, even just looking at this picture. So this is atrioventricular concordance. It's a normal situation. The first two segments are normal. How about in this example? So we saw the IVC on the right. So this is right atrium, this is left atrium. Look at these AV valves. Though this is connected here, this one is connected here. So is this mitral or tricuspid? Tricuspid. So can tricuspid belongs to RV, morphologic RV, we should say. Does it look more trabeculated and moderator band? So this is right ventricle. Left atrium through tricuspid is connected to the morphologic RV on the left side. So this is wrong. This is the atrioventricular discordance. This happens typically in congenitally corrected transposition. Okay. If you have a VSD, each valve should be fully committed, tricuspid to the right ventricle, let's say, and mitral to the left ventricle. But that's not the case always. The septum is shifted, and like in this example, this is the ventricular septum, there's a VSD, this is the tricuspid valve, it's overriding it. So we determine the commitment by 50% rule. If it overrides by less than 50%, it's still committed to the right ventricle here in this one. Here it's overriding too much on the LV side, more than 50%, so you say, yes, flow is more likely to be going to the left. It's more committed. This is more complex. Then there's the condition univentricular heart, we call. In old days, we used to use that term for this ventricle, this morphology here. Here you have two AV valves. This is tricuspid, this is mitral. Both of them are committed to this big ventricle, and this is called double inlet single ventricle. Both inflow tracts are committed to the same ventricle. And this has many different types, so I'm not going to confuse you, but this is the double inlet single ventricle morphology. But frequently now we see tricuspid atresia, like in this one. There's no tricuspid valve, and there's only mitral valve. They always have ASD, so all the blood is going from IVC, SVC through the right atrium, through this, all the pulmonary venous has to come into this ventricle. So it's called single ventricle physiology with tricuspid atresia. I mean, although there's a smaller right ventricle, which is hypoplastic, but essentially this is single ventricle physiology. Everything comes there, mixes, and goes to both arteries. Okay, so that could be a single ventricle physiology with hypoplastic right heart or tricuspid atresia. In this one, it's called the common ventricle when both valves are combined into one. That's a feature of endocardial cushion defect, and you have ASD and VSD. That's common ventricle. But this physiology could be also with the mitral valve. If you have hypoplastic left heart, there instead of tricuspid, it's the mitral which is atrial. There's ASD. Everything is coming from left atrium and right atrium through tricuspid into this ventricle. So our institution is famous for that, hypoplastic left heart. They need either Norwood or heart transplant. For this one, we do Fontan for tricuspid atresia, single ventricle physiology. Okay. So this one, tricuspid valve is absent. It's like a membrane. And you have right atrium, right ventricle, ASD, and this is a tricuspid atresia type of single ventricle physiology. Here you see the two AV valves, mitral, tricuspid and mitral. They're committed to this one. And when you do a short axis, you see the two holes there. These are tricuspid and mitral valve. And you see the three leaflets here. So that's the tricuspid, this is mitral bileaflet. So both are committed to single ventricles or double inlet left ventricle. This is too complicated, but you understand a little bit at least. When you look at this view, LV committed to the aorta here. No overriding, no defect. This is a normal situation. But if you have a VSD here, like in this one, aorta is overriding. but the valve is at the middle level. 50% is committed to the LV. So we just use the term overriding. In tetralogy, you have VSD overriding aorta, RVH, and pulmonic stenosis, which is not shown here. So those are the 4 lesions in TET. Okay. Forget about DORV. I took all the time. So how does echo help now? We'll go systematically and look at just something simple. Okay, we'll start. We don't know. We have a complex congenital. Let's say it's dextrocardia. You see the heart in the right chest, and you know that from chest X-ray. So you're going to see the heart sounds on the right too, right? So you start with the subcostal. This is a normal sketch. The blue vein is the IVC. This is the descending aorta. Liver is on the right side. So when we take a knife and cut it like this, it will look like this. This is the inferior vena cava. This is the vertebral body. This is the spinal cord. This is the aorta. So you see this appearance. You know this is normal. It's Situs Solitus. And these are the 4 different combinations which I already went through. So we are looking at a normal heart right now. So you saw that normal arrangement. The second segment is the ventricles. So we go to the 4-chamber view, and we cut it in a 4-chamber plane and display downward orientation, which is normal. So this valve is attached lower. So that's the tricuspid. This is higher mitral. This is smoother ventricle. Can you appreciate these features? That's the morphologic LV. You can't say this is thicker because the patient may have different lesions. And this is more trabeculated ventricle, and tricuspid lower, moderator band. So these are all features of the RV and the LV. So second segment normal. So on the echo, you see the same thing. RA, LA, mitral valve higher, lower, tricuspid, moderator band. So third, the arteries you see from this view. In the center is the aorta with the 3 leaflets. This is the anterior in the patient. This is posterior. This is patient's right. This is left. And this is the pulmonic valve. So it's on the left side. It connects to the right ventricle. And aorta is here, posterior. Right below that is the LV. Also, you don't know it's aorta from this view or pulmonic. You extend this artery, and it divides into 2 branches. So that bifurcation into right and left branch is a feature of pulmonic artery. So you know, looking at these views now, this is pulmonic artery, and this is anterior. It's connected to the right ventricle. Everything is correct. So we use 3 symbols. First one, Situs Solitus, capital S. Second one, ventricles, D-looping, because that brought the RV to the right. Third, S for Solitus arterial connections. So normal heart is described as SDS Levocardia. Okay. So you put all these features together now. The first view was this IVC aorta. So that tells you RA should be on the patient's right. LA should be on the patient's left. So go to the 4-chamber. We know in this one, these are correct. Then look at these features. Yeah, this is atrioventricular concordance, both sides. Then you look at these features. Yeah, this is PA bifurcation. So all 3 segments are normal. And this is pointing down in the left, so it's a levocardia. So that's a normal heart. And this is all complicated. You can have all sorts of misconnections. In complete transposition, first segment is correct. So let's look at this. This is very important. Maybe I can draw it, make you understand a little bit, and stop there. Because then dextrocardia will get more complicated. You're falling asleep, I'm sure, a little bit. Okay. Oh, we'll have to destroy these beautiful drawings here. So make a 4-quadrant like this. And right, this is left, this is anterior, posterior. This is the direction. So this is the right atrium, this is left atrium. Normal, right ventricle, left ventricle. Correct? Now we have to show the arteries. That's a little complicated. It gets confusing. So aorta is connected to the left ventricle. Is that posterior or anterior? Posterior. Is it to the right or left as compared to the pulmonary valve?
Right.
To the right. Okay. So let's. This is the midline. Let's draw a circle here. So I don't have to say anything. I put a circle. I connect it to this. Touch this. So that means it's connected to that ventricle. And that should be aorta. And that should be right. So if I draw another circle here and put this line of separation. So originally this was a truncus. And I told you there is a spiral septum that develops in it. It divides the arteries into two. So this became aorta in a normal case. It got connected to the LV. It's posterior artery. This one is anterior artery. And through a longer outflow tract, it got connected to the right ventricle. Now we have to do something else here. There are three leaflets. So in both of these. And these are called semilunar valves. These are called atrioventricular valves here. I should show this way. So 3 leaflet, 2 leaflet, bicuspid mitral valve. So you just draw a line in the center and then attach like this, divide it. And I'm going to put the holes here. So those holes are the coronaries. So if you know the diagram, you know everything. So there is a hole here. This is on the left side, so that must be the left coronary. This hole, right coronary. So in aorta, we have 2 anterior leaflets, right and left, 2 coronaries. And the posterior leaflet is called non-coronary, or posterior sinus is called non-coronary posterior sinus, or just posterior sinus. In pulmonary valve, there are no coronaries, but we have 1 anterior leaflet and 2 posterior leaflets. Is it clear? In echo, you see multiple jets. In pulmonic view, like you see that. There's a central PR, right? So that's coming from here. Many times you see aortic circle is here. There's a PR here. And you are concentrating. Is it coming from aorta or is it PR? Is it a bad defect or something normal? So that PR is coming from this commissure. Okay, that's the commissural PR. And you know by the timing, you know the same color, you know the same velocity. So this sketch is very important. So that's a normal connection. And I'll just give you 2 more. RA, LA, RV, LV. So everything correct so far? So what is this now? So we can write here Situs Solitus, D loop, Solitus connection of the arteries. So SDS is the normal sketch. We can write here Situs Solitus, correct, normal, atrial position. And here ventricles, D looping because RV is on the right side, LV on the left side. Now I connected the arteries wrong. So this artery is posterior, this is anterior. And the holes are in the anterior artery. So that is aorta. Aorta should have been posterior. In old days, pathologists looked at the heart, aorta is anterior, they called it transposition. Either it's complete or corrected. So it's always a transposition. Except then some other thing came, it's called anatomically corrected malposition. But forget about it. Generally, it is a marker of transposition when you see anterior. So now this PA, even if I don't speak, a diagram tells you PA, this is PA, this is on the left as compared to aorta, or aorta is to the right, and this PA is connected to the LV because that's touching the LV. So aorta must be coming from the RV, just looking at the diagram. Aorta is on the right, so it's called the D transposition. Transposition definition is there are 2 arteries, they are connected to the wrong ventricles. And generally aorta is anterior. If it's on the right side, you call it D. If it's on the left side, you call it L. So in this one, if you see the blood flow, the blue blood from 2 kV will come here, go to the right ventricle, and the blue blood is going to go into the aorta. Red blood on the left atrium through the mitral into the left ventricle will go to the PA. It's incompatible with survival because these are circulations in parallel. They should be series. Blue blood goes to the lung, picks up oxygen, goes to the left. Okay, so this is the complete uncorrected or detransposition, and this is emergency in a neonate. So you break the atrial septum so you can do the mixing because they have PFO initially, so they're okay. A few days they go south, acidotic. And so atrial septostomy, then we do the switch procedure, cut the arteries and connect to the right ventricles. Before we did the mustard procedure. In the mustard, the pulmonary veins are here, right, on the left side. So you put a baffle like this. So all this red blood you divert to the right ventricle, and then it will go into aorta. So physiology is corrected. There was one mistake, so we made another mistake. So 2 negatives become positive. So that's the atrial inversion surgery or mustard procedure. But the problem here is the right ventricle is working like left ventricle, right? So it's at a higher pressure, it fails. And they can have atrial arrhythmias, they can have sick sinus because we've messed up with the SA node by doing these things. So around 30s, they start having problems. So Dr. Jatin then came out with this concept of let's cut the arteries and put them where they belong. That's a complicated procedure also, but it works much better than this. Our Dr. Bailey has done fantastic on mustards. He was trained with mustard in Toronto Children, and his results are fantastic. I mean, I see 35, 40-year-olds still doing well. So that the third one, what we are understanding is this is the right atrium, this is the left atrium. Okay. Now I connect the LV here and RV here. So this is Situs, Solitus. This is L looping because we've inverted the ventricles. We put the LV on the right side because the tube went to the left during development. And then, so this gets the blue blood. This has mitral valve here now. And this gets the blue blood. It's on the right side. This is red here. So this blue blood is going to the pulmonary artery. It's going to get oxygenated, come to the left atrium through tricuspid valve on the left, morphologic RV on the left. It's going to go to the aorta. The good with this diagram is I've had patients, had cath, cornea anomaly, they don't know what they're doing. You have to change the catheters. We are screwed up in the cath lab, and still catheterizer doesn't know what's happening. So if you know this diagram, you know now I'm dealing with posterior and the arteries are flipped. So this diagram is very important. The two coronaries are posterior here in this one as well as in this one, instead of coming from the anterior sinuses. So inversus is there may not be any defect. So this is the LA, this is the RA, this is the LV, this is the RV. And LV has to connect with the aorta. Aorta is posterior. Aorta is, instead of being right, is to the left now. So this will be, first let's finish this. Situs, Solitus, L loop, and aorta is on the left side. So this is called the L transposition. And I just write in the report TGA colon SLL. So this describes everything. TGA is transposition of great arteries. Same way TGA, SDD, or D transposition or L transposition.